All right. Thanks for staying for the feature lecture, everyone. It's my pleasure today to welcome and to introduce Dr. Raymond Cho, who was born in Virginia and raised in Toledo, Ohio. Graduated from the United States Military Academy in West Point in 1990 and from the University of Cincinnati College of Medicine in 1994. After completing his general surgery internship at Brooke Army Medical Center in San Antonio, Texas, he spent 3 years as the brigade surgeon for the 1st Brigade, 82nd Airborne Division at Fort Bragg, North Carolina. He then completed his ophthalmology residency in 2001 at the San Antonio Uniformed Services Health Education Consortium. He served as Chief of Ophthalmology at Ireland Army Community Hospital in Fort Knox, Kentucky for 2 years, and at Keller Army Community Hospital in West Point, New York for 4 years. He also deployed to Balad Air Base in support of Operation Iraqi Freedom from 2005 to 2006, during which time he served as the ophthalmology consultant for the Iraqi Theater of Operations. Thanks for your service. Following a 2-year fellowship in ophthalmic, plastic, and reconstructive surgery at the University of Michigan Kellogg Eye Center, Dr. Cho was assigned to Brooke Army Medical Center from 2009 to 2012, where he served as assistant chief and chief of the ophthalmology service. He then served as the director of oculoplastic and orbital surgery at Walter Reed National Military Medical Center from 2012 to 2015, before retiring from the Army at the rank of colonel. His military awards include the Legion of Merit, the Bronze Star Medal, and the Order of Military Medical Merit. He also served as president of the Society of Military Ophthalmologists from 2013 to 2014. Dr. Cho has been the director of ophthalmic, plastic, and reconstructive surgery at the Ohio State University Wexner Medical Center since 2015 and is a clinical professor in the Ohio State University College of Medicine. He's an ASOPers Fellow and Fellow of the American College of Surgeons. He has served on several committees for the AAO and ASOPters and is a recipient of AAO's Achievement Award and currently Vice President and President-elect of the North American Society of Academic Orbital Surgeons. He has authored or co-authored more than 50 scholarly articles, book chapters, and research papers and presentations, is on the editorial board of Frontiers in Ophthalmology, and is a reviewer of several major scientific journals. In 2023, Dr. Cho participated in 2 humanitarian mission trips to Ukraine to perform reconstructive surgery on wounded soldiers and civilians. He is highly sought after nationally and internationally as a speaker and consultant for his expertise in orbital surgery. It's our pleasure to welcome Dr. Cho as he presents the faces of Ukraine.
So my talk is going to be split into 2 parts. I'm first going to give a talk on periocular reconstruction, just some general principles, and then I'm going to flow into my description of my mission trips in Ukraine. So just a disclosure, I'm just getting over the flu, which I've been fighting off for about the past 3 weeks, which was complicated by H. flu bronchitis. And then on top of that, I was skiing in Utah 2 weeks ago, and I suffered a left distal radius fracture. So it's been a little bit of a struggle for me, but I think I'm coming out of it on the other side. So when it comes to periocular reconstruction, there's many indications why you might need to do such a thing. Trauma, of course, is a very common situation. You have lacerations, you can have tissue destruction and loss in some cases, and burns in some other cases. Surgical trauma is also common. Tumor resections such as Mohs excisions of cutaneous carcinomas, congenital anomalies, and surgical misadventures, be it your own or other surgeons' surgical complications. And then cicatricial disease, such as one of the cases that we saw earlier today. It can be a cicatricial disease of the ocular surface or pyogenic pyoderma gangrenosa or other such unusual diseases. This picture is of a patient that I treated while I was a fellow. And this gentleman hit himself with a chainsaw in the face. And so if you hear that history and you look at this picture, you might think to yourself, there's no way that there's not some amount of tissue loss here. But in fact, when we got him to the OR and we looked at got all the pieces together, they actually came together quite nicely. I think the next slide is actually a picture of that. So, that's a picture from Iraq. I'm sorry. So there's a lot of questions that you have to ask yourself when you're looking to undertake a periocular reconstruction. Number one, if the lid is involved, is it a partial thickness or a full thickness laceration? In other words, does the laceration go through the lid margin? Is the tarsus involved? In which case, you're going to treat it in a different way versus if it was a partial thickness laceration. Is there tissue loss? As I mentioned before, sometimes it's going to be hard to tell in trauma. The lids are under a certain amount of tension, and oftentimes when there's a laceration, the eyelid tissues like to curl underneath themselves, and sometimes it can create the appearance of tissue loss when there actually isn't. So this is the actual patient that had the chainsaw injury, and you look at this and you're like, oh, there's got to be some tissue missing, but in fact, pretty much all the pieces were there except for maybe a tiny bit of necrotic tissue right here in the anterior lamella. What other structures are involved? Obviously, the globe is quite important to all of us in this room. Is there an open globe injury or some other injury? The globe is a canaliculus involved if it's a medial laceration. Is the levator involved? If there's fat coming out of the wound, then you know there's a violation of the orbital septum. The next structure underneath it, when it comes to the upper lid, is the levator aponeurosis. So you have to ask yourself if that needs to be repaired. And then lastly, how's the vascular supply? Now, in most cases of acute trauma, that's not usually much of an issue unless it's particularly severe. But in cases of secondary trauma, it can be a major concern. Have they had multiple surgeries in the past, such as a lot of the trauma or the cancer resections that we undertake? Has there been radiation? A lot of the ENT head and neck cancer patients that I treat have undergone adjuvant radiation, and that can very much complicate the results of periocular reconstruction. So some general rules of periocular reconstruction that you need to keep in mind. Number one, when it comes to the eyelids, no vertical tension on your repair. Replace tissue with like tissue whenever possible. So if you have tarsus missing, you want to replace it with something like tarsus. Tarsus from the other side is great. If not, you can use something else like auricular cartilage or hard palate mucosa or various other options. Make sure that there's an adequate vascular supply. If you're putting a graft, a free graft, you have to make sure that there's a good underlying vascular bed of tissue. You cannot put a graft on top of a graft because neither one have the vascular supply and they're both probably going to fail. Respecting aesthetic units is always a good idea. This illustration here shows the aesthetic as an illustration of the aesthetic units of the periocular region in the face. So if you're doing a flap, whenever possible, you want to make sure that you use different flaps for different aesthetic units. And then we're all familiar with the relaxed skin tension lines. If whenever possible, you want your incisions and your resultant scars to follow those relaxed skin tension lines for the best possible aesthetic result. So for full thickness eyelid defects, basically I like to divide them into small, medium, and large defects. For small defects, say anything less than 10, 20, 25%, you can often just do a primary closure, especially in older patients who have a lot of laxity. Sometimes if you need a little bit more room, you can do a lateral canthotomy and a canthelysis in order to just give you that just much less tension on your closure. For medium defects, anywhere from 30 to 50, maybe even 60%, depending on how old the patient is. Tensile flaps are often useful for this is classically described for the lower lid, but you can also do a reverse tensile flap for the upper lid. And then for large defects of the upper and lower lids, often lid sharing techniques are required. So for the lower lid, that's the Hughes flap, and for the upper lid, that's classically the flap. So when it comes to primary closure, this is how I like to do my primary closures. I usually put 2 sutures to approximate the lid margin. The first one is at the meibomian gland line, and the second one is at the posterior lash line. I like to do a vertical mattress because I like the wound edgy version that it produces. So this is kind of an illustration. So these are the 2 edges of the tarsus at 90 degrees. So the far pass comes first. That's about 2.5, 3 millimeters from the margin of the laceration. Your depth matches the length of the pass from the lid margin. Then you go on the other side, you match the depth and the size of the pass on the other side. And then you do your near passes, near, and then you sew them back together. So it's important to keep the dimensions of these passes in mind. So the blue arrows are equal distances, and then the red arrows, which are the near passes, are also equal distances. So once you have those sutures in place, oftentimes I'll kind of leave them loose so I can still see the edges of the tarsus. This patient is, by the way, just a pentagonal wedge resection for trichiasis. And so the purple sutures that you see here are the partial thickness sutures. Can you see my? Yeah, there it is. Our partial thickness passes through the tarsus. All right, you want to make sure you don't go full thickness, or else your suture will rub on the cornea. When it comes to the lower lid, because the lower lid tarsus is only about 4 millimeters in height, usually you can only get 1, maybe 2, if you're lucky, of these sutures. And for the upper lid, because it's about 10 millimeters, you can usually get 2, 3, maybe even 4 of these sutures in. And then once you have all that in place, you cinch down your sutures. This shows the popular mare's tail technique, where you leave the margin sutures long and tie it down with your skin sutures. I actually don't do that. I just use a 6/0 Vicryl, tie a couple extra knots in it, and then cut it very close to the knot so the knot doesn't rub on the ocular surface. And this is the patient's final result. So this shows a medium-sized defect. This is about a 50–60% defect of the full thickness of the lower lid after a basal cell carcinoma. So this demonstrates the semicircular incision that goes from the lateral canthus. It extends across the lateral canthus. You do a lateral canthotomy, and if you're canthelysis, and then that allows you to bring the 2 edges of the tarsus back together, do your full thickness repair like you normally would, take a little bit of a standing cone out, and then repair the anterior lamella. So this is a patient who required a Hughes flap after resection of a melanoma that involved the conjunctiva and the eyelid. This just shows ocular surface reconstruction that I performed with a umbilical cord membrane graft for the bulbar conjunctiva, and then a buccal mucous membrane graft to reconstruct the palpebral conjunctiva. And so this should just be a review for most of you, but the Hughes tarsoconjunctival flap is taken from the upper lid, leaving at least 4 millimeters of the upper lid tarsus behind, make a full thickness incision, dissect the tarsus off of the underlying Mueller's muscle, leaving a bridge of vascularized conjunctiva. You bring the flap, so here's the tarsus coming down into the lower lid, attached to the inferior lower lid retractors, and then a full thickness skin graft is placed on top of that. So this is a pre and post op from a different patient with a basal cell carcinoma after a Hughes flap reconstruction. For the upper lid, the Cutler beard flap is classically described, although there are other options, but this is a patient who had a large keratoacanthoma of the left upper lid. I did a resection with frozen sections, and then I actually like to use nowadays a modified Cutler beard flap. The classic Cutler beard flap is where you take flaps from the anterior and posterior lamella, bring them up into the upper lid, and then put a graft, a tarsal substitute graft in between those 2 layers. What I do nowadays is I take a free tarsoconjunctival graft from the opposite upper eyelid. I'll use that to reconstruct the posterior lamella, and then I'll bring the anterior lamellar flap from the lower lid. So this is the tarsoconjunctival graft, and then this is the anterior lamella, skin, and orbicularis brought up through a full thickness incision underneath the tarsus to reconstruct the anterior lamella. This is another patient who had that modified Cutler beard flap, had a full thickness loss of his upper lid from trauma, which was never reconstructed. You can see this large amount of lag ophthalmos. This is him in the interim before his flap was taken down. And then this is his post-operative result with full eyelid closure. So when it comes to partial thickness defects of the lids and paraocular region, there's many options that we have in our toolbox. You can have basic advancement flaps where you just move tissues around. You can do rotational flaps, which pretty much the name describes it pretty well. Transpositional flaps, where you have flaps that are moved from one part to another, but that kind of skip over tissue. And then interpolated flaps, the classic example being the paramedian forehead flap. There are also subcutaneous flaps that are available if you want to put a skin graft over top of it, or if you just need to provide reconstruction of the subcutaneous tissues. Temporal parietal fascia, temporalis muscle, and pericranial flaps are just a few examples of those. So, and there's also microvascular free flaps if you have large soft tissue defects. And of course, this requires a specialist in microvascular free flap reconstruction, where you bring a vein and an artery along with a flap of skin and sometimes even bone, and you connect it to a donor vessel. So the simplest way to close a defect is just to ellipse out the excess tissue and then close it back together. This is an example of an O to U reconstruction, where you're just taking a flap from one side of the defect and bringing it in. This is an example of an O to H, where you bring flaps in from both sides and they come together to form an H. O to T, similar concept, except you're just making an incision on one side. You're not making the incisions on the bottom here. O to S and O to Z flaps are two other examples of advanced flaps. This is a W-plasty. I don't really find much use for W-plasties in my practice. I don't know, me through if you use the W-plasty very often.
Sometimes I'll do it for telecampus soft tissue, but it's not the most common.
So this is an example of an O to Z flap, patient with an anterior lamellar defect of the preseptal lower lid. And the reason I did an O to Z instead of an O to H or O to T is because this more closely follows the relaxed skin tension line. So you have this triangular flap on this side, another triangular flap on the other side. They come together to meet in the middle, and it provides a nice aesthetic reconstruction. Rhombic flap is a very popular transpositional type flap. What you do is you basically imagine or create a rhombic defect, and then you have four choices. You can either go up like this, you can go on this side, you can go down here, or you can go down here. And the key is to make sure that these distances, this distance from here, these are basically like two equilateral triangles. So this distance equals this distance equals this distance equals this distance equals this distance here. So this distance from here to here is also the exact same thing as here, and then this distance is the same here. And you basically create your flap and you rotate it in, and you end up with a scar that looks something like this. A bilobe flap is another example of a transpositional flap, a little bit more complicated. So this is your primary defect. You're creating another rotational flap that's a little bit smaller than your defect. And then you're creating a second flap that's a little bit smaller than this to reconstruct the secondary defect. So this flap rotates in here, and this flap rotates in to reconstruct the secondary defect. So this is an example of a lateral canthus defect after a Mohs surgery, showing the rhombic flap. So this is kind of how I imagined that defect to be. I decided to take my flap from up here because I didn't want to take it here. That would have distorted the brow. I didn't want to take it from here or here because that would have created downward tension on the lateral canthus. So here's the patient's post-op result. Here's an example of a bilobe flap. I used the bilobe here as opposed to rhombic because there really wasn't any good options for a rhombic. Because it was closer to it would actually involve the pretarsal lower lid. So here's the primary flap here, and then this is the secondary flap to reconstruct the secondary defect. And here he is immediately post-op. Here's the primary flap, secondary flap, and then here he is post-operatively. Another flap I like to use, particularly in the medial canthal region, is the island pedicle or V to Y flap. This is a flap where your vascular supply comes from deep underneath the flap. So you actually do make full thickness incisions all the way around, but you keep a pedicle of vascularized deep tissue here, and then you advance your flap into the defect and then close this behind. And so that creates a V to Y reconstruction. Rotational flap, very simple concept. You just create an arc and then rotate the flap into the defect. Remove a little standing cutaneous deformity here and here, and that's what you're left with. So this is an example of a medial canthus defect where I use a glabellar island pedicle flap. I keep the deep tissue here as a vascular supply, make incisions here and here, advance the flap into place. And then here she is at the end of surgery. Here's an example of several different flaps being used at the same time. So this illustrates the concept of respecting your aesthetic units. So here's a squamous cell carcinoma that underwent Mohs reconstruction. You can see he has defects of the medial canthus, the medial lower lid, and the medial upper lid. So I don't want to use one flap to reconstruct all three of these. I use 3 different flaps to reconstruct each defect separately. So here is a flap from the upper lid and just a simple advancement flap brought over to here and attached to the medial canthal tendon. Here's a flap from the lower lid, subciliary incision, again, same concept. And then here's your glabello-island pedicle flap that I just showed you to reconstruct the medial canthal defect. Here he is at the end of surgery, and here's his final post-op result. Cervical facial flap is sometimes required to reconstruct very large defects of the skin of the lids or periocular region. This is a woman who underwent removal of a melanoma from the cheek. And so this flap extends all the way across the lateral canthus, the preauricular region, and down into the neck, hence the cervical facial flap. So this entire flap is undermined in the subcutaneous plane, rotated into place. This is a standing cutaneous deformity that's removed. This shows the flap being developed, sutured into place, and here is her final postoperative result. The one caveat that I would say that is if you're using a cervical facial flap, if there is a significant amount of preseptal or pretarsal lower lid skin that's missing, you're likely to, if you just do a cervical facial flap, you're likely to get a good amount of lower lid retraction. So I will usually combine this flap in those cases. If this defect were any higher involving this part of the lid, then I would usually place a skin graft to reconstruct that part of the eyelid. So this is an example of a paramedian forehead flap. This patient underwent a reconstruction of a defect by another surgeon. That reconstruction failed. And so he ended up with this defect of his lower lid. What I created was a flap based upon the supratrochlear artery here, extending all the way up to the hairline. This flap is then brought down into the defect and sewn into place. And this is an example of an interpolated flap. So there's a portion of the flap that's not reconstructing any of the defect. It's bridging over normal tissue. And so this is done as a stage procedure. So once this has had a chance to vascularize over about a month, sometimes longer for patients who are higher risk for failure, and then you take them back to the OR, you remove the portion of the flap that you're not using, and then inset the proximal portion in the brow. So finally, as far as grafts go, sometimes you can't do everything you need to just with flaps. And so for anterior lamellar reconstruction, the most common thing that we use is skin grafts. In order of preference, upper lid is great for any lid defect because it's lid skin. If you have an older patient who's got a lot of extra, you can use that. But if they're younger or if they have a defect that's larger than what you can get, then you got to go other places like preauricular, retroauricular, or supraclavicular. So these are probably my most common locations. After that, you can pretty much go wherever you need to. But the closer your donor site is to the lids, the better skin match, the thickness match, and the skin color match that you're going to have. As far as posterior lamellar reconstruction, autogenous grafts are obviously the most preferential. Tarsoconjunctival grafts, like I mentioned with the modified Cutler beard flap, hard palate mucosa grafts for the posterior lamellar, buccal mucous membrane grafts, or dermis fat grafts. Other grafts that are available, off-the-shelf grafts such as Enduragen or Alloderm, amniotic membrane. I have, like I showed you previously on that melanoma patient, I have used umbilical cord membrane. You can use amniotic membrane as well, but the problem with amniotic membrane is that it's very thin and it usually goes away within a few days to a week and it doesn't last very long. The umbilical cord membrane has the same advantages of as amniotic membrane, but it's 10 times thicker than amniotic membrane, so it tends to stay in place a lot longer and you get a more durable reconstruction. These grafts are not meant to stay there forever. They're just there long enough for the new conjunctiva to grow over the defect. And then you have other options that I never utilize, like Med4, Gore-Tex, and others. I don't like the idea of using alloplastic implants for post-lamellar reconstruction. So this patient is a burn patient, firefighter that I treated when I was in San Antonio with full thickness skin grafts to the upper lids. So here's a patient who had actually had a squamous cell carcinoma and a basal cell carcinoma of the same cheek. And so that was reconstructed by ENT. He came to me with severe cicatricial ectropion. So I used a supraclavicular skin graft to reconstruct this defect after I released the scar tissue. And this is fairly early, I think 6 weeks afterwards, but he ended up doing pretty well. Just to be mindful that when you use a very large full thickness skin graft like that, it does contract. All skin grafts will contract to some extent. And so the larger your skin graft is, the more contraction you're going to get. So I told this patient, listen, I'm going to put a huge skin graft on you. There's a very good chance that it's going to contract and you're going to need some further revisions down the road. But fortunately, he did pretty well. So just as a wrap up, these are kind of this kind of list of the periocular reconstruction techniques that I talked about when it comes to full thickness defects. You can just do a primary care repair. You can do a lateral cantotomy canthelysis. Tenzel flap is great for medium-sized defects. Hughes flaps and Cutler beard flaps are very useful for large upper and lower and upper lid defects. You have a variety of local flaps that are available for consideration, and then a number of different grafts that you can use for periocular reconstruction. Thanks. I'll take some questions before I move on to the next presentation. Any questions about that?
There's an ever-going discussion on the use of ice after full thickness grafting. Do you have any sort of thoughts or rationale behind your perspective?
I don't use ice after grafting. In fact, most lap reconstructions, I just tell my patients, just stay away from the ice because I want the vascular supply to be as robust as possible. Do I have to share again?
Yeah.
Okay. There we go. Okay, so as David mentioned, last year, I participated in two mission trips to Ukraine. So I appreciate the opportunity for me to talk about those trips for a couple minutes. I have no financial interests. Please, you can take photographs, but don't take any ones that include pictures of any of my patients. So when Russia invaded Ukraine, the full-scale invasion of Ukraine was in February of 2022, so almost 2 years ago. Since that time, casualties in Ukraine have been tremendous, absolutely horrific. Amongst the civilians, they estimate that 10,000 have been killed and at least 18,000 have been injured. Among the Ukrainian military, the Ukrainian government does not release official statistics, but as near as from American military estimates are that about 70,000 Ukrainian military have been killed and about 100 or 120,000 have been injured. Amongst the Russians, that number is believed to approach 300,000. So there's just been an incredible human cost to this war in Ukraine. When it comes to facial injuries, there's no way to know exactly how many facial injuries are involved with these numbers, but if you take numbers from past conflicts and extrapolate them to the current conflict in Ukraine, you make the assumption that up to 40% of combat injuries involve the face in some way, then you're looking at somewhere in the neighborhood of 50,000 Ukrainian soldiers and civilians who have some sort of facial trauma that needs to be treated. Clearly, the Ukrainian healthcare system is not equipped to treat this massive, overwhelming number of facial trauma patients. I don't even think the United States could deal with that many facial trauma patients. Many of these injuries are sent because they can't handle them in Ukraine. They're sent to neighboring countries like Poland and Germany. But in September of 2022, the American Academy of Facial Plastic Surgery decided to send a team of facial plastic surgeons to Ukraine, which to my knowledge was the first mission trip of American surgeons to go to Ukraine to try to to aid in the treatment of these patients. This team went to Ivano-Frankivsk, which is the same location that we went to, but this was kind of like the very first time that American surgical team set foot in Ukraine. Face the Future Foundation is a nonprofit based in Toronto. It was founded by a ENT facial plastic surgeon named Peter Adamson in 1996. They have, over the past couple decades, performed over 50 missions in Africa and Asia. When Peter recognized the need in Ukraine for facial reconstruction, he decided that he was going to try to do something about it. And so he partnered with Razum for Ukraine, which is a non-governmental organization based out of New York, mostly Ukrainian expats who try to aid with providing humanitarian assistance and medical aid to Ukraine. So this was in March of last year was the first mission that Face the Future Foundation had performed in a war zone. So they started planning in about September of 2022. They interfaced with a local ENT department in Ivano-Frankivsk. They started to collect patients. The ENT folks would put pictures and CT scans in a Google Drive, which that could be shared with the surgeons. And then on a weekly basis, they would review these cases and determine, okay, this is probably what we're going to have to do to treat this patient. A lot of these cases, because of how complex the injuries were, required or were greatly aided by the use of patient-specific implants, customized implants that were provided by a company called Materialize, based in Belgium, which is actually the same company that used to provide implants for Synthes Corporation. So at some point, they recognized at the beginning of the planning, it was all ENT facial plastic surgeons and a general plastic surgeon. They recognized that a lot of these injuries would really benefit from the expertise of an oculoplastic and orbital surgeon. So a couple of the surgeons who were at Houston Methodist contacted Amina Malik, who is also a Houston Methodist and a member of Ace Operas, and asked her if she could maybe reach out to the community and see if anyone was available to help. So she posted this message on the chat board, called DocManor for the North American Society of Academic Orbital Surgeons, and asked if there was anybody who might be willing to help. So when I first read this, this was in February, right? The mission's leaving in March, and I thought, at first glance, I'm like, there's no way. I mean, I've got like patients booked out, for several months, and I got to cancel clinic and ORs and everything. And then I thought about it again, and I thought to myself, with everything that you've been through, with your experience in Iraq, your experience doing secondary trauma reconstruction in San Antonio and at Walter Reed, and with your particular interest in treating trauma patients, is there anything else in the world that you really should be doing besides this mission? And so I decided no, that this was something that I really had to. I really didn't have any choice. I had to participate in this mission. So 24 hours later, I contacted Peter Adamson, and I was on board. A week later, and 6 weeks later, I was in Ukraine. So these are the two missions that I participated in. The first one is in March of 23, and the second was in October 23. The first team had 13 members, so 5 surgeons, 3 ENT, facial plastics / head and neck oncology surgeons, Anthony Brissett, Joel Kane, and John Frodel. General plastic surgeon, Irina Karinets, who's in New York City and is actually a Ukrainian expat who speaks fluent Ukrainian, and then myself. Peter Adamson is the foundation director and director of the mission. A anesthesiologist, and then 4 nurses, a photographer, and a representative from Razum, Ukraine, who helped to coordinate all the activities of the team. In October, we went with 3 more members, the same mix, but 3 more nurses. And so the second time we went, again, 3 ENT facial plastic surgeons, Priya Kasarwani from Toronto, Matt Brace from Toronto, Johnny Trites from Halifax, Nova Scotia, a general plastic surgeon, Natalia Biskup, also a Ukrainian expat from Wichita, Kansas, and then myself. Paul Slavchenko, who is also a Ukrainian expat, was our anesthesiologist, and then 7 nurses, Peter, again, a photographer who's actually taking the picture, and then a coordinator from Razum. So this is the location that we went to. Ivano-Frankivsk is a city in the western part of Ukraine near the Polish border. So as most of you know, most of the military action is taking place on the eastern border near Russia. So security-wise, you know, there wasn't any military action taking place. So it was relatively safe. This is the hospital that we worked in, the Ivano-Frankivsk Regional Clinical Hospital. So you can't fly into Ukraine these days commercially. So we flew into Poland, Krakow the first time, and then Warsaw the second time, and then drove a bus across the border to Ivano-Frankivsk. The itinerary for both trips was identical. Thursday and Friday, we flew to Poland, met at a hotel. Saturday, we got on the bus, drove to Ivano-Frankivsk. On Sunday, we had a medical conference that was concentrated on facial trauma reconstruction for local Ukrainian surgeons. On Monday, we saw all the patients that we were planning on operating on in clinic all in one day, just to make sure that, okay, that we knew what we were dealing with, and finalize a surgical plan, get surgical consents and everything. Tuesday, Wednesday, Thursday, Friday, we operated 4 days straight. Saturday, we drove back to Poland, and then Sunday, everyone flew back home. So, yeah, so here's some pictures. Here's meeting in Poland. Here's getting on the bus. This is the first medical symposium. Here's the clinic on Monday, performing surgery, getting back on the bus to Poland, and then flying back home. So this is the initial symposium that we held. In the hospital itself, there's about 100, maybe 150 attendees. It went very nicely. But the second time, October, they found another venue at the local medical university. There was at least 200, 250 attendees. It was very, very well done. There were actually translators there so everybody had headphones that they could receive simultaneous translation during the conference. And it was live streamed to hundreds of local Ukrainian surgeons as well. This is the ENT department that we coordinated with in Ivano-Frankivsk. These are some of the attending surgeons, and these are some of the residents. Now, it's important to point out that the graduate medical education system in Ukraine is much different from what we are used to here in the United States. So in Ukraine, when you become a doctor, you go through medical university. You don't go through undergrad and then through med school. It's 6 years, kind of like a flex program. So you go through undergrad and medical school all in 6 years. Then you do a residency. There's no internship. It's just a residency, and it's 2 years, regardless of what specialty you're in. It could be primary care, it could be ENT, it could be neurosurgery. It's 2 years for everybody, okay? And then you go and you start practicing. So when you're dealing with residents here at Ukraine, they are not at the same technical level as residents that you're dealing with here in the United States. So you're basically dealing at a skill level of maybe a PGY 1 or a PGY 2. So the need and the desire for surgical training for these residents was tremendous, and they were there. I mean, every time you turn your head, there's a resident right next to you trying to learn from what you're doing. I also had the privilege of being able to interface with the ophthalmology department in the same hospital. They happen to be on the same floor, just across on the other side of the elevators. So this is the chief and the chair and the vice chair of the ophthalmology department. And then Angela and Mariana were the two ophthalmologists in the department who actually did the bulk of their oculoplastic surgery. But it was, basically bread and butter, bluffs and ptosis and functional strips. So they really didn't have any experience with doing socket reconstructions, orbital surgery, DCRs, and anything like that. So here's the hospital. So the top floor right here is where the ENT department is. It's just one big long hallway. At the very end is a little door here that goes into their surgical suites. And then along the hallway, there are actually inpatient bed rooms. They admitted all their patients through the entire week, and the week before and the week of the surgery. Here is a procedure room that we converted into an OR, and then here is where we actually saw our patients in clinic. So Monday, this just some photographs from Monday, very, very chaotic. We had to get through 30 plus patients all in one day, all with trying to teach the local attendings and residents at the same time. You can see in this photograph here, there's at least 20, 25 people just within the frame of the photograph and others outside. Once we saw the patient, wrote down the surgical plan, then they would go to the next room. This is the procedure room where they would get consented and pre-op by our anesthesiologists. At the end of the day, we sat down as a team and we went through all the cases and decided on the surgical schedule. So the first time in March, this is how we did it. We had these Post-it notes and we would write down the patient's name, their information, the procedure, the surgeon on the Post-it note, and then we'd put it up on the wall and move things around until we got something that we thought was a workable schedule. And then we took pictures of it, and that's what we went on for the rest of the week. For October, we leapt into the 21st century and used an app called Miro, where we were able to put everything on the app. Everyone was able to have their own version of the app and see in real time. And it was much more convenient to be able to move cases around. We did a lot of that. And everyone was able to see exactly what was going on any particular day at any given. So this is the end of that hallway that I just showed you. This is the OR control desk. This is the door through which these two ORs, OR1 and OR2, are. OR1 is the only OR that had an overhead light. So having a headlight for myself was key. I actually happen to have an LED headlight that I can connect to a battery pack. So that was very, very important. And then OR3 was the minor room that I showed you, which was all the way on the other end of the hallway, which our original intent was just to do monitored anesthesia care cases. But our anesthesiologists were actually able to convert it into an OR where we could actually put people to sleep and do general surgery. This shows there was actually some people from Storts who came in and live streamed surgeries to local surgeons throughout the week. So these are some microphones that they gave to certain surgeons to wear so that we can narrate the surgeries as we're going along. So just a few action shots. You can see myself here, Johnny Treitz, Tanya Pavlicek, who's a oral maxillofacial surgeon from Lviv, both of us wearing these microphones as they're live streaming the surgery. This is Matt Brace and Talia Kamashko, who is the main coordinator for the mission on the Ukraine side, performing a perimedian forehead flap for nasal reconstruction. This picture kind of demonstrates the kind of teaching that went on. This is a cross-space facial nerve graft for a facial palsy patient. And so you have the team up here working on the face, and then you have another team harvesting the sural nerve graft for the facial nerve. And there's at least 12, 14, 15 patients, people in the frame of this picture, all just trying to get as much learning as they can. The Materialized team from Belgium, who created our patient-specific implants, very, very important. You can see right here them actually showing us during surgery the scans and the implants, and showing us anatomic landmarks to give us the best chance to get these implants positioned the best way possible. So we did 60 cases over the 2 missions. Both missions had exactly 30 patients. And out of those 60 patients, 35 were cases that I was involved in that required oculoplastic and orbital surgery. So this is the breakdown of the cases that I did. A bunch of fractures, 14 blowouts, the ZMCs, the translated wiring, a lot of socket reconstructions, 12 enucleations, 15 dermis fat grafts, a bunch of heart palate and bulk of mucous membrane grafts. A lot of lid procedures, as you would imagine, G-Hughes flaps reconstructions, 11 skin grafts, a bunch of lid malposition repairs, lateral canthotomies, wedge resections, 3 lid weight implantations for facial nerve palsies. And then as far as the face goes, several mid-face lifts, a cervical flap, browplasties, and 2 Z-plasties. And then as far as lacrimal goes, 3 DCRs. I think 2 of them were endoscopic and 1 of them was external, and then 1 CDCR where I placed a Jones tube. I only had like 2 Jones tubes with me, and as luck would have it, the exact size that patient needed was the size that I had. So, so total, if you add up all the procedures, 107 billable procedures. So these are the patients that I operated on. These are the 15 patients from the first mission, and these are the 20 patients from the second mission. So I'm just going to show you some examples of some of the patients that I operated on. This is a patient from the March mission who completely lost his left eye. His eyelids had severe, obvious deformity of his periocular region and face. When I looked at this guy, I told him, listen, I don't know what's behind the skin here. I don't know what I can do for you. I can open things up and I can try to reconstruct a socket so that you can wear a prosthesis, but I have no idea if there's any chance that it's going to succeed. He said, well, just give it a try. So I basically made an incision where I thought palpebral fissure belonged, explored the orbit. There was not much there besides fat, maybe a tiny little bit of conjunctiva here, possibly. So what I did was I placed the dermis fat graft in the socket, and then 2 buccal mucous membrane grafts to try to give him, to try to reconstruct the palpebral conjunctiva of the upper and lower lids and give him some semblance of fornices. This is him pre and post-op. Unfortunately, this reconstruction failed. Several months later, pretty much everything just kind of shriveled up. He was not able to wear an ocular prosthesis, but it was an important learning experience for me. And this emphasizes the importance of vascular supply. This guy had no vascular supply whatsoever. And so if I were to do this again, if I was willing, it would probably require some sort of flaps, maybe a paramedian forehead flap to reconstruct the lids, maybe a temporalis muscle flap, bring it in the orbit to provide some vascular supply, maybe a nasal septal flap that you can bring in through a medial canthus incision. But this is just an example of sometimes things don't work when you want to. This patient lost his right eye, had an evisceration, had some bony defects as well. He had a defect of the supralateral orbital rim and an orbital floor defect that they created a patient-specific implant for. We decided not to use this, not to have a PSI made. We just used MedPore sheet to reconstruct the supralateral rim. And that part went just fine. But when I got into his orbit to put a dermis fat graft in or whatever, this is what I found. So here's the scleral remnant. And then inside, you can clearly see uveal tissue, okay? And so it turned out, I did about 11 of these, and every single one of them looked the same. They had this shriveled up scleral shell and then uvea inside of it. So the first time I saw this, I'm like, well, I can't leave this in here. You know, what if he develops sympathetic ophthalmia? So I just did a completion enucleation, put a dermis fat graft, and then called it a day. This is a patient I also treated. I treated on both missions. So the first time he came in, he looked like this in March. I tried it. He had already actually been operated on already by the September team from the AFPS. They had done some orbital fracture repair with a PSI, and he actually looked pretty darn good. I told him, I'm not sure how much better I can make you look. And this is him afterwards. Honestly, really not looking that much better. But the reason he came back is because he developed this exposure of his orbital implant that had been placed the year prior by the AFPS team. And he had this fistula because there's holes in the implant. So he was blowing air from his maxillary sinus into his socket. So what we ended up doing to repair this fistula was a pericranial flap. So we opened up this brow scar that he already had. We developed a pericranial flap here. You can see it in situ. And then we reflected down into the socket and used it to cover this exposed implant here. So you can see it in place here. We haven't sutured it yet, but we used it to, this was also not just to reconstruct repair the fistula, but also to provide a little bit more fornix for his inferior fornix and his medial fornix, which, as you can see here, was pretty contracted. So I don't have any post-op pictures from him, but he ended up doing well, had no recurrence of this fistula. This is another patient that I treated on both missions. This is from the March mission. Obviously lost his left eye and had severe comminuted fractures of his zygomatic maxillary and buttresses. So you can see he does have some upper lid here. Most of his lower lid's gone. He does have some conjunctiva here. So in March, what we concentrated on was reconstructing his face, mostly. So we have these PSIs made by Materialize, and this shows repositioning of these bone fragments. To be totally frank with you, the thought that we would be able to reposition all these fragments in a perfectly on time location, that's a pipe dream, okay? But we did the best we could. We have to have something to aim for. And so this is what he looked like post-operatively. And honestly, it doesn't look all that bad. His orbit's looking pretty good. Unfortunately, his zygomatic arch, there's still a pretty big gap in it. But from an orbital standpoint, I was pretty darn pleased with this. However, when he came back, and also I did a Hughes flap reconstruction to reconstruct the lower lid defect. So this is him, multi-disc skin graft. And then afterwards, about a month later, I gave the local ophthalmologist instructions on how to do the stage 2 takedown of the Hughes flap. Actually, as soon as I got back home, I took a video of a Hughes flap reconstruction that I did and then sent it to them, and they did the takedown, and he did really nicely. But he came back in October looking like this. So he is able to wear a prosthesis. His cheek looks pretty good, but he still has some pretty significant orbital dystopia. His lid, he's got a pyogenic granuloma here. He's got lateral canthal dystopia, and he has pretty significant enophthalmos as well, okay? And the inferior fornix was pretty contracted, so there was very, very little fornix. So what we proceeded to do was place a dermis fat graft in his socket, release the scar tissue, made an incision all the way across underneath here to release the anterior lamella, release the posterior lamellar defect. The problem is that when you release both anterior and posterior lamellar defects, you have a full thickness defect, big hole in the lower lid. You can't put a graft over that. So what I did was a rotational flap from the lateral canthus and cheek, rotated that in, took this piece right here, this piece of skin that I had to remove anyway because of the standing cutaneous deformity, and used that as a skin graft for right here, where he still had posterior lamellar intact. So this is what he looked like at the end of surgery. Here's the rotational flap. Here's the skin graft, bulbomucous membrane graft for the posterior lamella to recreate his inferior fornix, and again, the dermis back graft. And so this is his result. He's very happy, and I'm very happy too with this. It took 3 stages. So first the facial fracture, Hughes flap, reconstruction, then a stage 2 Hughes flap takedown. And then this guy also had that partial evisceration. So I did a completion enucleation, dermis fat graft, bulbomucous membrane, both into skin graft right here, and the rotational flap and a lateral canthopexy. And so he's got a pretty decent looking socket. Here's a patient with a ZMC fracture, significantly displaced. You can see his malar eminence is way down and out here. Also lost his eye. So here's the PSI designed by Materialize, 2 PSIs, one for the orbital floor and one for this missing bone of the superlateral orbital rim. So we repositioned. We had to do several osteotomies to free up this zygomatic segment, got that repositioned, put this PSI into place, put the other PSI along the orbital floor, completion enucleation. Here's his post-op scan. And here he is with a very nice result, able to wear a prosthesis. Cheek looks much better. We did do a full thickness graft to the upper lid, which contracted quite a bit because of the poor blood supply. But I think this is a pretty darn good result. I am going to skip to this will be the last case here. So this is a patient who obviously has severe trauma and bony loss of his cheek and maxilla. He lost his eye, and he has severe trauma to the lids. Now, you may look at this and say, well, this looks a lot like that first guy that you treated from the March mission. Why do you think this is any different? Well, the key here is that right here, there's a little bit of a palpebral fissure right here and right here. So this is actually ankle abutment. And so my hope was, if I release this, maybe I'm going to find some socket in there, some conjunctiva, some normal, something of normal lid tissues. So we designed a PSI, 2 PSIs, one for the anterior maxilla, one for the orbital floor and inferior orbital rim. Opened up the scar that he had in his cheek, put the PSIs into place, did a cervical facial flap to reconstruct his anterior lamellar defect. I did some revision of his eyelids, and this is him immediately post-op. This is post-op CT scan, and this is his a later post-op result. So he's got a socket, he's got a dermis fat graft. Yes, there's some orbital dystopia, lateral canthal dystopia. He may need some revision here, but he's got a socket. He should be able to wear a prosthesis. He's got a conformer here, and his cheek scar obviously looks much better. He's got very good projection. So I was very happy with this result as well. I'm going to skip over this last one for the sake of time. We are kind of at our end. Yeah. Okay.
Last case?
Yeah, you want it? Okay. All right.
I mean,
this is the last
fascinating.
So here's a patient, again, severe bony loss of his facial buttresses. This is a sighted eye, actually. So he kept his eye. He's got this severe scar and deformity of his cheek and this large festoon due to the loss of lymphatic drainage. So 3 PSIs. This is the most complicated PSI case that we had. So 1 PSI for the inferior rim and the orbital floor, another PSI for the anterior maxilla, and a 3rd PSI for the zygoma. And the thing that the engineers at Materialize did, which they had not done before, was they made little tabs. So here's a tab in this PSI that fit into this little hole into the maxillary PSI. And then the maxillary PSI had another tab here that was designed for this zygomatic PSI. So they were interlocking PSIs. This was a hell of a case, but very happy with how things eventually went. We got the PSIs, I think, reasonably positioned. And this is him, his late post-op. unfortunately, we're not able to get a post-op CT scan on him. Did a festoon excision, which looks better. There's still a little bit of a festoon there. He's got some lateral canthal dystopia, but I think this is a good start for this patient. So obviously, teamwork, very, very, very critical. Both missions we had on the very last day on Friday night, we had a celebratory dinner. We invited everybody who was involved in the mission to come and help us celebrate. But I put this picture in here just to highlight how many different teams of people were critical. These are the surgeons from Canada and the US. Here are the ophthalmologists that I worked with, the ENTs here, Natalia Kamashko, who was the main point person in Ukraine, Peter Addison, who was our mission leader, translators, absolutely critical to the success of the mission. We had an army of 8 translators, nurses, and the materialized team. This is a true team effort. And I think the mission went as smoothly as you could possibly. Of course, there are hiccups along the way, but we dealt with each situation. And I think at the end of the day, we were able to provide some pretty darn good care and education for the local Ukrainian surgeons. So the last day, a Saturday, we did our last rounds with the patients, said goodbye, drove back to Poland. This is our after action report that we did on the bus on our way back to Poland. And then we all headed back home. So a lot of things that were involved, you know, as far as the keys to success for the mission, obviously you have to pick the right people to participate. Planning was absolutely critical, communication between all members of the team, teamwork, absolutely essential, leadership from Peter Adamson. The second time, he actually asked me to be the surgical team leader. We also had a nurse team leader. And so we all had to kind of work together to make sure that everything went as smoothly as possible. Flexibility, obviously, when you're in a country that doesn't have the same kind of resources that we have here, you have to adapt to situations where you don't have the things that you are used to having here in the United States. Developing relationships, going back a second time for me was just absolutely just delightful to be able to work with the same Ukrainian surgeons that I had worked with the first time and to continue those relationships. And I do plan on going back this October again to the same location. So just to wrap up, before I went on the first mission, my partner, Shruti Akella, who had just come on board at Ohio State, gave me this as a gift. And for those who aren't familiar with the work of Sir Harold Gillies, he is considered the father of modern plastic surgery. And he got his experience through treating facial wounds in World War I. So if you have any interest in the history of facial plastic surgery, pick this book up by all means. When I started my career in 1994 at Burke Army Medical Center, this is the old Burke Army Medical Center in San Antonio. It's no longer used as a hospital, but this inscription is at the top of the portico every time I walked into the hospital every morning. And this kind of became my guiding light through my career as a military surgeon. Whatever your feelings are about the military and about wars, and my personal feelings have evolved a lot over the years. These patients, these soldiers and civilians in Ukraine that are defending their country against Russian aggression, they need help. And it was an absolute privilege for me to be able to go over there and provide the little bit of help that I was able to, and more importantly, pass on some of my knowledge and skills to some of the local Ukrainians so they can continue to provide care for the brave men and women who are defending their country. So this is a picture from the New York Times, just kind of, to me, represents the Ukrainian soldiers who have been defending their country for almost the past 2 years. Thank you very much.
Thank you so much. Thank you for serving our country. Thank you for serving the international community. Thank you for sharing that experience with us today. It was powerful.
You're welcome. Thank you.
All right. And I'd just like to present you with this special plaque to commemorate your visiting professorship here today at the Flaum Institute. Yeah, thank you.
Yes. Let's see, let's make sure it's no one's.
Are there any questions? Nobody? Please.
Thank you so much. That was an incredible talk. Could you just talk a little bit about the patient selection process? I mean, I'm sure the need was overwhelming, and how did you determine which cases to take on?
Yeah, I mean, that was a very difficult thing because the local department in Ivano-Frankivsk, they must have screened several hundred patients. We got it down to like 60-ish that we actually reviewed, and then we had to whittle that down to 30. So we had to kind of weigh, we had to consider, okay, who are the patients that we can help the most with the limited resources that we have, with the limited amount of time that we have, and with the skill set of the particular set of surgeons that we have. So yeah, it was a process, and we met, you know, like every week for several months over Zoom to determine who we were going to operate on. Any other questions? Yes.
I wanted to see if you could speak on just like the interval change that you noticed with the residents and the trainees from the mission trip in March and then the mission trip later.
Yeah, definitely. You could tell, you could see a difference. One of the things, I think one of the procedures that they had never done in that department when we arrived in March was paramedian forehead flaps. And we did several of those, and we did even more of, like twice as many the second time we went. So not only did they get to learn how to do paramedian forehead flaps, which is a pretty basic procedure for most ENTs here in the States, but they had never done them. And then they got to learn how to do the stage 2 takedowns of the flaps. They got to see their final results. We may have done 1 or 2 revisions when we went back in October. For myself, I was able to teach the local ophthalmologist how to do dermis vac grafts, both to do skin grafts, you know, things like that, things that they weren't familiar with. So, and a lot of these patients that I treated were like pretty simple, you know, this patient's enophthalmos after they had her eye removed, all they need is a dermis vac graft. And so now I don't have to go back and treat those patients anymore. They can do it themselves. Yes.
How would you, what was the method of communication with the local ophthalmologist after you left regarding post-op issues for the patients that were?
WhatsApp. Yeah, literally.
WhatsApp.
We were all on a WhatsApp group, and they would you know, send photos, ask questions, everything. We did a couple also Zoom calls. We did like at 1 week we did a Zoom call, and then a month we did a Zoom call. We might have done another one at like 3 months, just to kind of run through all the patients, make sure we had, you know, questions, you know. Yeah, so communication is critical. But WhatsApp is a great app.
You could maybe share some tips on how to optimize multidisciplinary surgery whenever you've got multiple surgeons that are going to be operating in a very close field.
Yeah.
Any tricks that you've picked up to allow for optimal success?
You know, every situation is different. You know, you're going to have a different, usually a different group of surgeons in the room. You're going to have a different patient who has different procedures that need to be performed. So you have to kind of get to know the people on your team and what they're capable of, what they're comfortable with, what they're not comfortable with. And yeah, that was another one of the big challenges was when we put together this big OR schedule with the patients on it, who's going to do which case? Yeah. So hammering out, you know. But you know, when you're in there, you kind of have to check your ego at the door, and you know, because you have to recognize this, you know, as much experience that I have, you know, there are things that I don't know how to do, or don't do as well as some other surgeons on the team. Hey, you know, why don't you do this certification facial flap? You know, I've done some, but you've probably done 5 or 10 times as many as I have. So.
What were some of the, I know you spoke that there were some hiccups along the way, and I was wondering if you could speak a little bit about what some of those were relating to either, setting up the eventual OR for it or whatever it was. I was just wondering if you could speak a little bit about any of those and kind of how you as a member of that surgical team kind of overcame it or worked with your other team members to get there just in that kind of circumstance.
I think probably one of the main issues that we had during the first mission was sterilization of measurements. We had a sterilizer that we had somebody had purchased for us specifically for the mission, but it wasn't large enough to fit most of the trays that, the instrument trays. So, and then the hospital, of course, had their own sterilizers, but the people who ran those sterilizers, they didn't work past whatever 4 o'clock in the afternoon. So, so that was one of the main issues we ran into in the first mission. We had to kind of figure out ways to break down sets or use other sets that, to just do what we had to do. And then the second time around, we came back and we're like, okay, we're going to make sure that this thing is taken care of. And it went much smoother the second time. But there's always little things, like one time they couldn't find the lid weight that I wanted to use for a particular case, so I don't even remember, but I had to figure out another solution to get a lid weight in that patient. Yes, ma'am.
I'm curious about like the partial eviscerations and the lack of SO that you were seeing in those cases. That the cranial surgeons talk about, like why they potentially leave uveal tissue? Was that ever discussed?
Yeah, unfortunately, we never had the opportunity to talk to the actual surgeons on the front lines who were doing those procedures. They clearly weren't ophthalmologists. So I don't know. They're probably just general surgeons or whatever, or I don't know. But because I talked to the local ophthalmologist and said, hey, did you know that this was happening? They're like, no, we had no idea. So, and I honestly don't know who the best people to talk to are, but at least the local ophthalmologists are aware of the issue and maybe they can figure out how to address it.